Before we even talk about numbers, charts, or the structure behind America's $4 trillion healthcare system, we need to start with something much more human, a feeling millions of Americans carry quietly every single day. It's that subtle tension in the back of your mind, the awareness that one medical emergency could rearrange your entire life, not just your health, your savings, your plans, your sense of stability. And what makes this feeling so heavy is that it exists in a country with some of the most advanced medical technology in the world, a place where breakthroughs happen daily, where innovation seems endless, and where the promise of care has never sounded more reassuring. Yet the lived reality is the opposite. People avoid checkups, families postpone treatments, workers hope injuries heal on their own, not because they distrust medicine, but because they distrust the bill that follows it. You don't need a policy report to understand this crisis. You feel it when you open a premium statement, when you argue with a billing department, when you realize the covered service you relied on wasn't really covered at all. This video begins here, in the gap between what the American healthcare system claims to be and what it actually is for the people who depend on it.
How can the richest nation in human history produce a healthcare system where a routine, non-emergency procedure can cost more than a full year of middle-class income? This isn't just a contradiction. It's the first sign of a deeper architecture, one most people never get to see. Every year, Americans work harder, earn a little more, stay a little later, pick up one extra gig, yet remain one unexpected medical event away from financial collapse. That tension isn't in your head. It's not paranoia. It's the emotional footprint of a system built with structural risk embedded into its very design. Because while national healthcare spending rises faster than the country's total income, the health of the population barely improves. That mismatch looks like failure from the outside, but inside the system, it makes perfect sense. A model driven by corporate incentives doesn't reward efficiency. It rewards opacity, the ability to charge without resistance, negotiate without oversight, and profit inside layers the public never sees. And that brings us to the investigative turn at the center of this story. The real crisis isn't just the price of care. It's the network of intermediaries, secret billing negotiations, administrative expansions, and financial engineering that transforms confusion into revenue streams. Most Americans assume healthcare costs come from medicine itself, but a huge share comes from everything wrapped around it, the part of the industry designed not to heal, but to extract. For families, the result is painfully simple. They enter hospitals seeking care, information, reassurance. They leave with debt that dictates where they live, what they can save, and how securely they age. This crisis didn't explode overnight. It's been unfolding slowly, steadily, one bill at a time, an erosion of middle-class stability so subtle and so constant that it feels normal, until you look closer and realize it has a design.
In a normal market, prices work like signals. They guide decisions, they shape competition, they force companies to justify what they charge. But in American healthcare, the signal is missing. And when the signal disappears, the entire logic of the market collapses. Patients enter clinics, hospitals, urgent care centers with no idea what anything costs. Not the test, not the doctor's time, not the room, not the equipment. You don't get an estimate. You don't compare options. You don't negotiate. You simply hope the bill won't destroy your finances. And that single missing piece, transparent pricing, removes the only mechanism that keeps costs in check in every other part of the economy. Behind the scenes, hospitals and insurers negotiate prices in private. These contracts are confidential, protected, and often unreadable even to the professionals who work with them daily. When prices differ from hospital to hospital, or even from one insurance network to another, no one outside these negotiations is allowed to know. And here's the hidden incentive. When no one can see what others charge, competitive pressure disappears. Providers can raise prices year after year without facing the usual consequence, losing customers. Because the patient isn't choosing based on cost. They're choosing based on urgency, fear, or whatever their insurance allows. And that leads to a counterintuitive truth that shocks almost everyone the first time they see it. More hospitals don't necessarily mean lower prices. More technology doesn't make care more affordable. More investment doesn't reduce costs. In healthcare, adding supply can actually make everything more expensive because price isn't set by the patient. It's set by intermediaries who profit from higher numbers. That's why an appendectomy can cost $2,000 in one state and $40,000 in another, with no clear difference in quality or outcome. The patient has no tools to interpret this gap, and the hospital has no obligation to explain it. If you want to imagine how this feels from the inside, picture a grocery store where nothing has a price tag. You fill your cart with what you need, walk out, and weeks later, a series of companies privately decide how much you owe. Sometimes they send you 3 or 4 different bills. Sometimes the totals contradict each other, and you have no room to contest any of it. This is not a market failing. It's a market that was never allowed to behave like one. If the American healthcare system feels overwhelmingly complicated, that's not an accident. Complexity isn't a side effect, it's an asset, a tool, a mechanism that quietly transfers power away from patients and toward the expanding network of corporations positioned between you and your doctor. Here's the paradox at the heart of this chapter. In most industries, intermediaries help organize the system. They streamline processes, reduce chaos, create efficiency. But in U.S. healthcare, every new layer makes the system harder to navigate and more profitable for those who insert themselves into the middle. This is what economists rarely say out loud. Healthcare has evolved into an intermediation economy, a place where the space between the patient and the provider generates more value than the medical service itself. And once you see that, the architecture becomes clear. PBMs negotiate drug rebates that no patient, pharmacist, or doctor ever sees. Insurers build networks with rules so complex that entire departments exist just to decode them. Hospitals employ teams of coders whose job is to maximize the billable opportunities hidden inside each visit. Manufacturers, distributors, data brokers, and third-party administrators create contracts that operate like financial engineering, shaping prices far from the exam room. This is the economy of artificial complexity. Layers not designed to improve health outcomes, but to expand the number of transactions. Every layer takes a slice. Every slice raises the total. And the human consequence is unmistakable. Insurance premiums rise while coverage shrinks. Deductibles climb. Out-of-pocket caps grow, and families pay more each year for less practical protection. The administrative overhead, the paperwork, the approvals, the billing systems now exceeds that of every other developed nation. Americans aren't paying more because care suddenly became more effective. They're paying more because the chain between the doctor and the patient keeps getting longer. To understand this system, think back to the American railroads of the 19th century. Each company owned a short segment of track and charged monopoly prices for its portion. A train traveling across the country wasn't paying for distance, it was paying for the number of companies it passed through. Today's patient experiences the same journey, not through railroad stops, but through intermediaries. Each one charges a toll. Each toll comes wrapped in technical language. And the total bill, once it reaches the patient, feels impossibly high because it reflects not the cost of care, but the cost of every gatekeeper along the route. And this is the part almost no one talks about.
The more intermediaries the system creates, the harder it becomes to reform, because every new layer builds a constituency, a set of corporate interests that benefits from the existing shape of the market. This is the hidden engine of rising healthcare costs, a structure where value comes not from healing people, but from inhabiting the space between them and the care they need.
Americans are told they can choose the best plan. It's one of the core promises of the system: freedom, autonomy, flexibility. But the moment the plan is chosen, the reality shifts. Because what people actually pick isn't freedom. It's a map of restrictions they won't truly understand until they need care. This is the misinterpretation at the center of modern insurance. On paper, plans look like options. In practice, they are networks, tight, conditional, and full of boundaries the patient only discovers by crossing them. The most powerful example of this is out-of-network billing. It operates like a financial trapdoor hidden inside the system. A misdirected ambulance, a hospital that isn't in your network, a specialist you didn't choose. These aren't decisions the patient makes. They're decisions made for you, often in the middle of stress or crisis. Yet the price you pay afterward can rival a down payment on a home. Even with high premiums, even with employer-sponsored coverage, consumers aren't buying healthcare. They're buying conditional access, a permission structure negotiated between corporations, not a guarantee of care. And this leads to one of the most damaging consequences. Millions of people delay scans, skip preventive care, or avoid specialists entirely because they cannot predict the cost. Not because they don't value their health, but because the system has trained them to fear the unknown bill more than the known symptom. The irony is brutal. The system saves money today by discouraging people from seeking care. And then it spends far more later when untreated conditions become emergencies. This isn't mismanagement. It's a structural incentive baked into the design. To understand this collapse, you need one mental model. Choice disappears when information is asymmetrical. When patients navigate in the dark and the system operates with full data and full leverage, the result isn't autonomy, it's dependency disguised as freedom. A marketplace where the consumer cannot see the rules, the prices, or the boundaries, yet is held responsible for crossing them. And once you recognize this pattern, the entire promise of choice begins to look less like empowerment and more like a carefully engineered illusion.
Across most of the economy, inflation rises and falls with global markets. Energy, food, consumer goods, they fluctuate, sometimes painfully, sometimes predictably. But healthcare is different. It moves in one direction only, upward. And it does so with a consistency that defies economic gravity. That's the paradox shaping American life right now. Even when overall inflation cools, healthcare prices climb. Not because of temporary shocks or supply chain disruptions, but because the system is built to increase costs automatically. The hidden driver is a set of multi-year contracts and price escalators that shield major healthcare corporations from competitive pressure. In nearly every other industry, companies are forced to adjust, to innovate, to lower costs, to respond to market reality. But healthcare remains insulated, protected, a sector where inefficiency isn't punished, it's monetized. And this protection produces one of the most striking comparisons in global economics. The United States spends more per capita on healthcare than any developed nation, yet ranks lower in life expectancy, maternal outcomes, and management of chronic diseases. The numbers don't add up unless you understand the structure, because the real financial hit doesn't show up only in medical bills, it shows up in wages. Every year, employers divert a larger share of total compensation into rising insurance premiums. Salaries appear stagnant,
because they're quietly being redirected into a system the worker never sees. On paper, wages look flat. In reality, workers are earning more, but the increase goes straight into healthcare inflation before it ever reaches their bank accounts. This is the silent pressure shaping middle-class life. People feel poorer not because their work lost value, but because healthcare quietly absorbs the value before it materializes. Globally, the contrast is even sharper. Many countries treat healthcare as a form of public infrastructure, a stabilizer that supports economic resilience. The US treats it as a financial marketplace, subject to layers of intermediation where each layer claims a cut. And this design creates a kind of permanent headwind, a structural inflation that grows regardless of economic cycles, squeezing households year after year. This is the cost Americans feel every time they postpone a dental visit, stretch a prescription, or hope an injury heals on its own. It's not just medical inflation. It's the architecture of a system that funnels economic pressure into the lives of ordinary people, quietly, relentlessly.
When you step back from the details, the billing codes, the hidden negotiations, the contract loopholes, a larger pattern comes into focus. And it's here that the story of American healthcare stops looking like a sector-specific failure and starts revealing something deeper about the direction of the entire U.S. economy. Because the truth is this: healthcare isn't an exception, it's a blueprint for how powerful American systems increasingly operate through opacity, intermediation, and extraction. Healthcare is simply the clearest expression of that logic because its consequences are so personal, so immediate, and so financially severe. The final revelation is unsettling, but necessary to see clearly. The U.S. healthcare system is not in emergency. Emergencies are sudden. Emergencies are obvious. Emergencies demand action. This is different. This is structural decline. Slow, methodical, built over decades, reinforced by incentives that reward the very pressures families struggle against. And once you recognize this structure, the pieces fall into place. Misaligned incentives ensure that the people paying the most have the least power. Concentrated corporate control creates choke points throughout the system. Dependency networks lock patients, employers, and entire regions into arrangements they cannot realistically escape. The system promises protection, but its incentives create fragility. The result is a model that erodes financial security year after year, even as it advertises stability. And that leads to the future implication we can't ignore. Unless the underlying incentives are redesigned, not patched, not tweaked, but fundamentally realigned, the cost of living in America will continue to rise not because of traditional inflation, but because other industries learn to replicate the healthcare playbook. Education, housing, insurance, utilities, any sector shielded from competition can drift toward the same architecture of complexity, fragmentation, and extraction. Understanding how healthcare works is not just understanding one crisis. It's understanding the mechanism behind many of the pressures reshaping American life. This is the quiet truth. Nothing in this system is accidental. It has followed a consistent internal logic for decades, largely unchallenged, because it was built to be difficult to see from the outside. But once you see it, you start asking a different kind of question, one that extends far beyond hospitals and insurance networks. If healthcare now operates like a financially engineered system rather than a public service, what other parts of American life are quietly moving in the same direction? And that question may matter more for the country's future than the healthcare crisis itself.